Good evening, everyone. I'm Christine Young, an MHA candidate at Cornell University and a project coordinator for the American College of Healthcare Executives Southeast Texas chapter. I'd like to welcome you to tonight's session of Palliative Medicine, personalized care for patients and family in the community. We would like to thank our chapter strategic partners for their support for this program and our other educational events. Our chapter member sponsors, Texas Children's Hospital, Houston Methodist, CHI St. Luke's Health, Memorial Hermann Health System, MD Anderson Cancer Center, and HCA Houston Healthcare. Our Diamond Plus sponsors, Metastar and the Intercontinental Houston Medical Center. Our Diamond sponsor, UTMB Health. Our Platinum sponsor, Harris Health, HKS, Kindred Healthcare, Legacy Community Health, Luminaire, Page, Reality Trust Group, the Cinderelli Company, Texas A&M University, Texas Women's University, University of Houston Clear Lake, and EAPB, as well as our silver sponsors, Berkeley Research Group, Brazos Sport College, Condeo Partners, EYP, and the UT School of Public Health. A special thank you goes out to our 2022 digital platform sponsor, Cheryl McCleary, Relocation Specialist Realtor with Brookshaw Halfway. Please note, we have several upcoming events of interest, all of which you can register for at www.ach-setc.org. Registration is open for a number of these events. Join us virtually for Cocktails with the Chief, featuring Lindsay Crane on Wednesday, August 18th, virtually to learn about Lindsay and network with other colleagues. On Thursday, August 25th, we're holding our third quarter breakfast meeting and panel, COVID-19's pandemic long-term fallout, persistent effects on chronic and acute disease management, in both in-person and accessible virtually. There are a few spots left for Saturday, August 20th, community service event at the Center for Success and Independence. Our acclaimed Fall Board of Governors exam review course is starting on Thursday, September 8th, so sign up today and take your membership to the next level. We have 3 fun networking events coming up as well, a virtual guided rum tasting on Friday, September 9th, a mocktail mixer social on Thursday, September 15th, and expand your palette painting and wine on September 22nd. Stay tuned for additional event announcements as many other events are currently in development. Don't delay and register today. Please join our mailing list, LinkedIn group, and our brand new Instagram to keep in touch with upcoming news. I will now hand things over to Dr. Robert Hillard. Dr. Hillard, the floor is yours.
Hey, good evening, everyone. It's great to be here. And thank you for coming out and hearing this very interesting topic. So I figured first, the bios of our speakers are attached, but we'll take a minute just to sort of say our names and what we do, and then we'll sort of jump into questions. And I'll go first. My name is Bobby Hilliard. I'm an OB-GYN by training, and I currently work for Legacy Community Health. It's been a long day. And we are a community health center in the Southeast Texas area. And why don't we go to Dr. Green next?
Good evening. Can you all hear me okay?
Perfectly.
I'm Avel Green. I am a physician at Baylor Scott & White in Temple, Texas. I am an internist by training, also board certified in geriatric medicine and hospice and palliative medicine. I am blessed to work in a system that allows me to unite these two passions. I serve as the division director of geriatric medicine here and also the medical director of Baylor Scott & White Hospice. As such, I am able to provide home-based primary care, which is often palliative, and I'm also able to provide hospice care at the end of life, which is the final segment of the palliative care pathway. Happy to be here tonight.
Right, thank you, Dr. Green. And in alphabetical order, why don't we go with Dr. Min next?
Sure, my name is Dr. Zach Min. I am the Director of Value-Based Care for Houston Methodist Coordinated Care. That is our accountable care organization with Houston Methodist working in value-based care and population health. I'm a director in a non-practicing role, so fully administrative, but I lead clinical teams and direct strategy for managing large populations of patients.
Good, thank you. Dr. Rizvi.
Well, thank you and good evening, everyone. I'm Ehsan Rizvi. I have recently joined the Texas chapter, very brand new, moved from Minnesota after spending almost 14 years at the Mayo Clinic. I am a geriatrics and palliative care board certified physician. Prior to my recent role with Baylor College of Medicine, St. Luke's Medical Center here as the director of geriatrics and palliative medicine, I was leading the oncology hospitalist palliative care program at Mayo Clinic for the last 14 years. So I am happy to be here. Most of my work is inpatient consults on palliative care patients, mostly in the intensive care unit, cancer patients, and patients with serious chronic illnesses in the hospital setting. Happy to be here.
Thank you, Dr. Risby. And Mark Young, Mr. Young, sir.
Hello, Mark Young. I'm the Chief Executive Officer of Community Health Network. We're a federally qualified health center, Brazoria County, Galveston, and in Southeast Harris County. I've been in community health delivery since 1995, and it's just been an exciting couple of years, and we've been moving more and more into home-based care, and so that's our interest in the presentation tonight. Thank you.
Thank you, Mr. Young. I appreciate it. All right, why don't we jump into questions? So I guess for everyone, we're going to kind of level set. What does community-based palliative care mean to you? What does it do? Dr. Green and Dr. Risby to follow.
Yeah,
Go ahead, Dr. Green.
Thank you. Thank you. I want to make it clear that although we normally talk about palliative care towards the end of life, palliative care is an important part of medicine at every step of the journey. It simply means attending to symptoms and making sure that people, although they may have pain or shortness of breath, we're doing everything that we can to alleviate that so that they are not suffering in an undue way. And so I wanted to make sure that first thing I say is that palliative care should be a part of all medicine across the continuum. For me, community-based palliative care simply means taking that model and bringing it to the patient wherever they live. So here we provide house calls through our geriatrics home-based primary care program, and much of that care is palliative. Many of our home care patients who are homebound elders have end-stage diseases. Some of them are on hospice, some of them are not. Some of them are ready for hospice, some of them are not. Some of them are eligible for hospice, some of them are not. And so what we seek to do is to provide the palliation of symptoms in the home and hopefully keep them out of the emergency room in hospital, and then guide them into hospice if and when they become ready so that they don't have to cross the huge hurdle of a hospitalization just to get good end-of-life care.
Thank you.
Excellent points, Dr. Green. I think everything that Dr. Green said, I will just summarize. If there's one thing I want every single person in this panel to go home today with, is the simplest myth that is out there is that palliative care is end of life. It is not. So the one thing I want everyone to go home today with is palliative care is not end of life, but end of life needs palliative care. So just like Dr. Green said, palliative care should be involved across the spectrum of a chronic serious illness to help with symptom management and quality of life of patients to relieve suffering through a multidisciplinary approach with physicians, nurse practitioners, physician assistants, nurses, pharmacists, chaplains, most importantly, to deliver the quality in the environment which is suitable for the patient to keep them as peaceful near their family. So again, palliative care is not end of life. It can be given and administered at any age, at any stage. End of life needs palliative care, hospice. Those are all very different things. Hope that message just resonates and you all can spread the word around in your own community circles as well.
It does, and I know that, because what you both touched on is something that is very confusing to people who aren't in the field, right? They sort of do think that hospice and the palliative care, it's been a long day, guys, are the same. So how do we then say, look, how do I explain the difference between chronic care management and palliative care in the communities and between them? So Dr. Min and then Dr. Green.
Sure. I think that it's very important to start that education with patients early on. I think that you're right. It's confusing to those outside of healthcare, and it's actually very confusing to those in healthcare. They don't know how to order palliative care, right? Because Medicare, I work with mostly Medicare patients, and so Medicare has a status for home health. They have a status for hospice. You put in an order to go on home health, you put in an order for hospice. There is nothing that's necessarily recognized by Medicare as palliative care. They're not on a palliative care program, right? There are home health companies that provide palliative care. There are hospice companies that provide palliative care. There are individual physician groups, like we heard, that will go out and provide palliative care services to those patients. But for some reason, it's not recognized as, a specific status. And so that's why we have this confusion with patients saying, oh, palliative care is hospice or hospice is palliative care. There's a lot of patients that don't like the term hospice. They think you're giving up on them. And so they think, oh, well, you've just rebranded hospice into palliative care so you don't hurt my feelings, but you're not going to, get one over on me. It's the same thing. So I think early education, working with patients in a, kind of level setting manner of what can be provided and what is to be expected with each of these different levels of care, the more that they're educated, the better decisions that they can make.
Love
I
the fact.
agree. Oh, I'm sorry. I really agree with that. And I'm glad that you uncovered the skepticism that we often face when we're called in to help patients. So the way I explain it to people is palliative care is important if a patient with chronic disease burden has significant symptoms that impact their quality of life, which is why, as Dr. Rizzi said, any age, any stage. Hospice becomes more important towards the end of that continuum. And then also, if the treatments that we have to offer for cure are no longer acceptable to the patient, sometimes people don't want the burden of the surgeries and the chemotherapy and the radiation therapy. So either they are in a place where those things are no longer being offered to them, or they're being offered to them at a cost that is unacceptable. And I don't mean financial cost. I mean the cost of symptom burden. And so what I like to use with providers, because as you said, many in medicine are confused, is the surprise question. Would you be surprised if this person passed away in the next 6 months to a year? If the answer to that question is no, I would not be surprised if this person passed away within the next 6 months to a year. They most certainly need palliative care and may even need a hospice referral. So that's the way I provide the education to providers. On the patient side, what I say to families, caregivers, and patients is hospice and palliative care doesn't mean we're giving up. It doesn't mean we have nothing else to offer. That is never true of medicine. We always have more to offer. And what I explain to them is as aggressive as we would be about cure, if it were available, we are going to be just that aggressive, if not more, about managing your symptoms and making sure that you are as comfortable as you can be with the time that you have left. We're not putting you out to pasture. We're not giving up on you. We are simply changing the goals of our treatment plan to focus more on making you feel as good as you can with the time that you have left.
Thank you, Dr. Green. So question, we've talked a little bit about it. So what are the benefits of community-based palliative care? And then what are some of the obstacles? Let's go with Mr. Young and then followed by Dr. Green.
Well, I think the first thing what we're looking at as an organization is that we want to be part of that, be a fuller continuum of care, and really bring more whole person and expand whole person care. And this is a real opportunity to do that. So we're working with more and more people, especially think about Brazoria County. While it's considered urban, it is very rural in nature. People live in the country. They're pretty, a lot of times we face a lot of social determinants of health issues, transportation, time, help, mobility issues, just tons of things. So being able to reach out to those folks and go back out to them and go to their homes, keep them connected to their healthcare is where we feel like we're moving in strong into that area. So the palliative care, while we are not really in practice providing palliative care at this time, we are providing chronic care in the homes, and this is an extension of that next level, I believe.
Great, thank you, Dr. Green. I'm sorry, Dr. Min, forgive me.
Sure. So, you know, while we don't necessarily provide palliative care either within our organization, I think that it's important. As I said, I have clinical staff underneath me working with the large populations of patients. So our largest program is our Medicare Shared Savings Program. We've got about 43,000 lives that we cover. And we have something that really resonated with me that Dr. Green said is we have an advanced illness care program that is telephonic nurses reaching out to patients who have been stratified through risk analytics as being in the last 12 to 18 months of life. And we have that exact same conversation with the physicians. We bring them out this list of, okay, here's all 43,000. We've narrowed it down. We've got these patients that look like they're in the last 12 to 18 months of life. Would you be surprised if they passed away within the last or in the next 12 months? And the answer is, you know, either yes or no. And that gives us our list of who we're going to contact. We do this outreach, and you know, the phone call is not, hey, you want to start hospice. It's a very, you know, sensitive discussion, and it really requires a deft hand. So we have some nurses that have both been trained, both have worked in hospice companies, but they start that conversation with the patient of really more chronic care management, complex care management, which we also have a program that does that. But let's talk about the different conditions that you have. Let's talk about how you're managing those symptoms. And then it kind of eases into, you know, what are your goals for end of life care? Let's talk about what you want out of life. And oftentimes, if you catch that early enough, you can have the conversation with the patient instead of waiting for the patient to be unconscious in the ICU and trying to have it with 5 children that don't agree on what's best for mom, you know. So you really have to have that conversation early so that people are eased into it and they are thinking about end of life with a level head while they still feel good. If they're in the point where they're no longer feeling good, maybe they're short of breath more often than usual, there's a little anxiety around having that conversation because, oh my gosh, they're talking about end of life. Is that tomorrow? Do they think that's tomorrow for me? If you get it a year in advance, they're still feeling pretty good. So let's talk about it. Let's see what I would want while I have a clear head to think about it. So I really appreciate the kind of skills of the nurse, you know, the background they have to be able to have that conversation. It's a special person that can really start that conversation and develop that trust with the patient and get them to start getting some education and really give that feedback about what they want for end of life care.
Thank you. So most of us have heard of sort of the two. What is the difference between primary and then specialized palliative care? Dr. Min, then Mr. Young.
I'll defer to Mr. Young or Dr. Green. I mean, for us, we don't have a kind of a difference necessarily in primary versus. I don't know myself, so I'll defer.
Mr. Young or Dr. Green, can you comment?
I'll just say that I think that, you know, there's in primary care what we do, and, you know, as fairly qualified health centers and providing to low income or sometimes uninsured people, we have to extend the care that we give outside of primary care often. And so I would see that is probably I would think the difference is, what a primary care provider can do outside of what someone more trained and prepared for to provide that care.
Yes, I agree with Mr. Young about that. The way I think about it is primary palliative care is the palliative care that every physician should be trained and prepared to deliver. And so all of our patients at some course in their illness, whether it's acute or chronic, will have pain. All of us need to have some proficiency at pain management, both acute and both chronic. However, if you have a patient who has significant pain with multiple dimensions, some of it is somatic, some of it is existential, some of it is neuropathic pain, some of it is musculoskeletal pain, some of it is visceral pain, and they need a PCA pump at home, right? That requires specialty palliative care. And so that is how I explain the difference between primary palliative care and specialty palliative care. Primary palliative care is what all of us should be prepared and trained to deliver. Specialty palliative care requires that additional expertise that those of us who've done fellowships and/or are board certified in palliative care have been trained to deliver.
Thank you. Very educational. So I think what I've heard a couple of times now is that we think that if you ask a patient or a physician, would they be surprised if their patient was not around in 12 months or 18 months, right? And let's say the agreement is, I would not be surprised. Is there an access to care problem once they say, yes, I want to engage in palliative care? How does that process work with approvals and all kinds of stuff that may have to happen with payers? Let's see, Dr. Green and Dr. Min.
So once I ask and answer for myself the surprise question, because it's an interesting question to ask to people, to patients, not one that they're often prepared to answer. So I won't say that I've never used it with a patient. Sometimes you'd be surprised at how much people know about their prognosis, and they're just waiting to hear us say it. They know they're dying. They know they're at the end. They know they have more time behind them than in front of them. And they're just waiting to hear us say it. They're waiting for us to give them the okay to pursue comfort-focused treatment. But once that question is asked and answered by the provider, then the next step is to really turn to the patient to figure out how much they know and understand about their prognosis, and then perform an assessment of their symptoms to determine if they need primary palliative care or specialty palliative care, as I've already explained, or are they ready for hospice? And so you asked a while ago what the importance of community-based palliative care is. Many times when people access emergency services through the ED, they're doing so because they don't feel good. And if they have a chronic medical illness that is at the end stages and they have exhausted all of their treatment options, then we need to have a healthcare system that is flexible and agile enough to provide them the kind of care they would need where they are. Because if we cannot do that, if we don't do that, they will seek care in the emergency room. And for them in that moment, it is an emergency. So we get really surprised when people show up in the ER because they are in distress with their symptoms. But if we don't create other pathways for them to receive the care they need at home in the community, we've given them no other choice. And so if you can cut that off at the pass, the next step then would be to make a referral to a palliative care specialist if you have one in your community. And if you don't, you most certainly have home health and hospice agencies. Many hospices, for example, will provide what we call education-only visits with no strings attached and no expectations. They will simply come perform an assessment in the patient's home and explain to them what kinds of services they offer and how they can help them meet their needs, give them some reading material so they can talk it over with their family, And if they choose, they can elect hospice. That requires a process that they have to sign up for, elect to have the Medicare Part A hospice benefit, and then hospice services are then covered through Medicare Part A. Because palliative care is another specialty of medicine, it's covered by insurance just the same way, for example, a referral to a cardiologist would be. So in terms of explaining that difference to the patient, it really is, depending upon their insurer, these are services that are offered, and how the provider makes the referral and bills for them will determine whether it's Medicare A or whether it's Medicare, et cetera. I try to help patients not worry too much about that, because that burden is really not on them. What they want to know is, can you make me feel better? And can I afford this? Does my insurance cover this? And so I try to focus for them on what they will gain in terms of symptom management, and then leave the nuances of the payment piece to other people. There is one caveat to that. If you have a person living in a skilled nursing facility, for example, there are some financial implications to whether they're receiving palliative care versus hospice in a skilled nursing facility. If they've come from the hospital and they're doing skilled rehabilitation, that's a Medicare Part A benefit. Medicare will generally only pay for one Part A benefit at a time. So it's very difficult, not impossible, but very difficult for a person to be in a skilled nursing facility, getting skilled rehab and hospice, because both of those are Part A benefits. If they elect hospice, then they become responsible for the room and board. And that has significant financial implications for some people. So there are some caveats and some nuances to that we don't necessarily expect a primary care provider to know, which is why it's important to go ahead and make that referral to palliative care and or hospice, because we'll be better versed in answering those questions and helping to guide the patient towards the care that's most appropriate for them.
Thank you. So you touched on saying that, that some hospice places will actually do sort of informational visits, right? But overall in the community, who does do the palliative care sort of treatment? Is it one company? Is it a team? Is it different people coming together to do it? And what's it like in your organization? Dr. Rizvi and then Mr. Young.
Sorry, yep. So at our organization, obviously we are a very small group at the time, 3 physicians, a nurse practitioner, and a chaplain. The ideal delivery of quality palliative care, I would say, has to be a multidisciplinary approach. Physicians, advanced practice providers, hospice nurses, chaplains, as well as hospice and palliative care pharmacists who help us deliver the medications that we need to alleviate symptoms after completely checking and making sure that those were safe for the patients. Obviously, every organization differs, and I would, through this audience, like to convey that right now, almost every organization is working short-staffed, overworked, overwhelmed. So nurses, physicians, APPs, everybody is literally stretched thin right now. And so a question just came in the panel that are we seeing a lot more palliative care consults because people are getting delayed screenings, delayed appointments? And the answer is yes. I mean, especially at our institution, what we have seen is patients who have been waiting for appointments, couldn't make it, ended up in the emergency department, much more sicker, ended up in the intensive care unit. And therefore, that's when a lot of palliative care engagement initiates. One change that we had to bring in our organization is engage the 2 key players, the intensive care unit and the hospitalist sections, to engage palliative care early. Because a lot of times what was happening is everything has been done, patient's not been doing well, and therefore now palliative care walks in, where the family is already frustrated by a lot of things. Now you're walking in, try to be the pleaser and calming down effect. Doesn't work that way. If you develop a relationship early on, from day one when they come in, the patients families begin to trust you more. And that's when, if you have to transition the cares during the hospitalization, it tends to work a lot more smoothly because they trust your opinion at this point. And that they have seen that how you have been a part of their journey for sometimes weeks to months in the hospital. But all of that really depends on how much you're able to do, depending on what your bench strength is. And right now, at least in our organization, I've sort of witnessed firsthand how short-staffed and overworked the nursing teams and the physician teams are. So maintaining quality is a challenge, yet all of us strive to deliver quality care every single day in whatever circumstances we might be in.
Thank you.
Well, I've mentioned, I think that we've just started this movement in this area over the last couple of years. And so a little over a year ago, Dr. Jolly Sun reached out to me. She wanted to talk to me about what her mission is. And so we were talking about palliative and hospice care. And what we did as an organization, we started off educating all of our staff members about end of life from a personal perspective, actually. And it was shocking to some people, but interesting to most everyone. So this was a way for, I think, us to have a better understanding when we do talk to patients. There was a little resistance, actually, from folks who didn't want to address it, period. And these were younger people, which was sort of surprising. And then where there was also pushback that, from a risk management standpoint, which really didn't hold a lot of water, I don't think. But we're still on this journey, and I think we're going to continue to make it more normal to discuss within ourselves, and that way we can have an easier conversation for patients.
Great, thank you, Mr. Young. Appreciate it. And then I'll go back to Dr. Green, maybe to Dr. Maybe. I know he's really deep in the ACO space, but you mentioned Medicare paying for these services, no problem at all. Any commercial insurance hiccups or Medicaid hiccups? Is it typically also equally easy to get those paid for?
Yeah, I mean, sometimes we have patients that are unfortunate enough to fall through the cracks and not have either. But we take care of patients. Now, I'm talking about hospice. So understand that when I answer questions, that is my primary clinical work as opposed to palliative care. So with hospice, yes, we have all commercial payers, traditional Medicare and Medicaid. And then occasionally we will have patients that are younger, so they don't have Medicare, and they may be too well resourced to have Medicaid, and so they're not adequately insured, or they're uninsured completely. And what we try to do with our hospice is take care of those folks. And so as a physician, I make clinical decisions about eligibility, determination of eligibility, and leave the business decisions to the folks in the business office. However, we do have a foundation that helps support this work. We've got a hospice thrift store where we raise money to support this work, because at the end of the day, as a healthcare system, here's the truth. We will take care of people regardless. The question is, are we going to do that with ER recidivism? Are we going to do that with recurrent readmissions and hospitalizations, expensive ICU stays that they don't want? Or are we going to do that at home with home-based primary care, palliative care, and hospice, which is often a much more economically efficient way to provide the care, and actually the kind of care that people want? If you ask most people, if you knew you only had 1 year to live, how would you want to spend it? I would challenge you to find someone who says, I'd like to spend my last year of life in and out of the emergency room, and in and out of the hospital, and in and out of the ICU in a skilled nursing facility. I've not found that person yet. And I ask that question a lot. Most people want to spend their last year at home surrounded by the people who love them in a place that they're comfortable with their symptoms well managed. And so identifying those people early, getting through those challenges of payment, if there are, I think is really important to our long-term goals of reducing the cost of healthcare in this country.
Thank you.
We've gotten very innovative with the way that we've worked around it as well. We've seen that for some of our Medicare patients, it's, palliative care provided by hospice. It's kind of straightforward. The hospice company bills as hospice and provides it as palliative care. We've seen home health companies actually stepping up outside of their bounds. And so it's home health, but they're also going to have a 24/7 nurse line, and they're going to provide a few extra visits that they normally would not under traditional home health. We've also seen to kind of find a way to add on top of that, geriatrics visits, right? So home visits through geriatricians, and it's just a either virtual or inpatient, or not inpatient, in-person visit to the home, billing out as a specialist face-to-face visit. So there's ways around it to provide the same resources of what would be a kind of piecemeal program, but we need to get those resources to the patients. It's just finding ways around it to get it, billed and get them the resources they need, however we can do it.
Okay, thank you. All righty, a topic that is discussed all the time these days. How does community-based palliative care fit into value-based care models? Dr. Min, I know you live and breathe that space, and Mr. Young, I know you are going, you could knock your doors knocked on all the time about value-based care. So Dr. Min first and Mr. Young.
Sure. I think we've addressed a lot of this already, but if we just want to take it from what we've said in, what's best for the patient, what they want, it actually correlates. What's good for the patient is good for value at the same time. They don't want to spend the rest of their time going in and out of the ED, going in and out of the ICU, long hospital stays. That's actually bad for the hospital system as well, right? It's bad for value. It's overflowing EDs with patients that could be at home and comfortable, instead for those on the hook for the cost and utilization, like an accountable care organization or a full, managed care program. Each of these recurrent ED visits, recurrent, readmissions for the same thing over and over again, could be taken care of at home. So we see that the more that we get patients, to the appropriate level of care, be it, additional resources at home on a palliative care program or to hospice earlier rather than later, we see that decreased ED utilization. We see decreased readmissions. We've even seen patients that are in our advanced illness care nursing program, just the nursing outreach to talk about advanced care planning, to talk about the different level of, resources available to patients. That alone will decrease the number of admissions for a patient. So just starting that conversation and making them aware of what other options are available instead of just going to the ED. A lot of people get scared and they go to the ED. And when you go to the ED, they're going to put you in the hospital, right? The ED is there for triage and quick management of what to do. And if you come in and you're sick, they're going to put you in a bed and go on to the next one. So we've got to get ahead of that. And we actually have, even within our inpatient system, we have case managers and social workers that sweep our EDs. They go and see when one of our Medicare Shared Savings Program patients shows up, they say, is this, admission necessary? Can I get this person home with the appropriate resources? Can I get them a follow-up visit tomorrow with somebody that'll come to their house? Can I start hospice from the ED? Yeah, it's possible. We actually have. So these kind of programs, getting patients the appropriate resources at home and getting them to understand what palliative care really is, stops that overutilization and that heroic end-of-life care that often doesn't lead to any, better length of life or quality of life.
Thank you. Mr. Young.
Yeah, we've, as I mentioned before, we really look at the care we're providing as a continuum, and even in the moving into the home-based world, even preventive care and We're moving in to have our own home health. We're finalizing on some credentialing right now. So we're looking more for the value-based care side of that to control cost, be able to lower that, and be able to give patients what they need, including the support services in their home, is what we're looking to achieve. And from a value-based care perspective, I mean, it's just the whole package is critical. We have a RPM system that we've put together. We've got a team now. We've got a number of patients on this program, and we're now putting a little geek squad team actually together to go out to the homes and actually make sure that they stay connected to their devices and all. So it's all just a big part of a big picture of moving out, and it's exciting, but we have a long way to go.
Thank you. Thank you, Mr. Young. So I've learned a lot tonight for this evening. So how do we promote this, right? How do we continue to bring awareness and education about the benefits and where the care for palliative care is just really on a continuum and not just a synonymous or with hospice. So how do we do that? How do we promote awareness for this? Dr. Risby, I think everyone can answer this question. Dr. Risby, Dr. Green, feel free to chime in, Dr. Min, Mr. Young. Great question.
So, as a father of 2 teenagers, newspapers don't matter, TV ads don't matter, books don't matter. So we have to innovate ourselves as the palliative care community in how we approach and deliver the message. So what I would say is all of us, in our personalities, and I'm working hard on it as well, is re-innovate our personality as not the dull, boring guy who always comes in and talks about serious issues and makes us all cry and then offers hankies and Kleenexes. No. You have to use humor sometimes when it's appropriate. And then the next level of community palliative care messaging literally has to go through social media, I would say, through small snippets. I would tell you that this current generation that needs to be educated, and even our generation, has literally lost its attention span down to 5 minutes. So 20 years ago, I could sit through a talk for a whole hour, 45 minutes, and I'll be just as attentive. Now, after half an hour, either I'm engaged or I'm gone. So the message has to be delivered in small snippets of power value information delivered, boom, and there you go, with a punchline that sticks. And that's how the message is going to spread. Oh, did you see that guy? Oh, he's gone viral. So nowadays, everything is about going viral, people. So if we can't go viral with our message of palliative care, we won't go too far. That's how I see, and that's what I'm trying to work on. My kids say that when I try to be funny, I just overdo it. So I'm just trying to curb that a little bit. But that is where I will work on with our group eventually, once we have full bench strength, to sort of develop these small educational videos on TikTok or Instagram where anyone can just browse through and kind of have 2 minutes of good educational learning and spread it around. That's my take on it.
Dr. Risby, will you have a dance for us to all watch and learn?
Hey, why not? Why not? Anything for the patients, and whatever delivers the message with an impact. That's what matters.
Awesome. I'm going in order of my screen, Dr. Min.
No, that's such a great point. And I will tell you, we're working with a company now, and I have no financial investment in this company, so I will just say clearly it's not for me. But we've worked with a company that came out of the TMC Innovations Institute that was working on this very problem of advanced care planning education involving, the difference between hospice palliative care and why it's important to start advanced care planning early. But what they did is break it down into small bite-sized educational snippets, and they have it in, either an app you can watch on your tablet, or they have a web link. And we've been using this with our patients, and it's small, broken down videos that focus on different things each time. What's important in your life, religion, family, things that, all play a role in the decision that you're making. And it asks questions that allows you to kind of come to a good decision about what you want for advanced care planning, while providing small educational snippets of 2 minutes at a time. It's not something they're going to sit through for a long time, but it was a very novel idea, and they've grown it into a full company, and they've done a really great job with it. We've worked with them more and more, and we're writing a research paper with them currently, trying to see if we can expand this even further. But this has been huge for us, and we've gotten great feedback from our Medicare patients that aren't necessarily always the tech savviest ones. They're not on the TikTok. Thank you, Mark. Looking for things, but yeah, they still want short snippets that are still at an easy to understand educational level that helps them make their decisions. And this company has gone one step further, and as the patients watch the videos, answer the questions about themselves and what their decisions may be, they're able to actually populate an advanced care planning documentation, an advanced directive, and the company can then get it notarized and sent back to the primary care physician to keep in the PCP's office and add to their EHR. So very interesting idea, and I'm glad that some people are already working on it. But I agree definitely with what you said.
Thank you. Again, in order of my screen, Dr. Green.
So I am Black on social media. In other words, you cannot find me anywhere but LinkedIn right now. So I'm going to let Dr. Risby make the TikTok video. I do think that one of the most untapped resources we have in the healthcare system are patients and caregivers. So I'm a firm believer in identifying those people who can really be advocates and firebrands. That requires us to come out of the ivory tower, out of the hospital, out of the clinic. Now, as I said, I'm a doctor who makes house calls, so I'm going to be biased in this. But I think if we sit around and wait for people to come to us to get all their questions answered, we're going to be waiting a long time. We've got to get out and beat the street. I rarely turn down an opportunity for community events. So when people ask me to come speak, oftentimes they'll ask me to come speak and they won't even have a topic. Guess what? I get to choose what I talk about. And sometimes I will have topics around advanced care planning and end of life decision making, because it's not a normal part of our society and the way our culture approaches healthcare. We approach death like it is a problem to be solved, a reality to be changed, but it really is a reality to be accepted. And so normalizing those conversations around the dinner table, I think, is really important. And then when you plant those seeds in people, then they have conversations with their mom or their aunt or their Uncle Joe or whomever it is. The other thing that I think is really important is, and I know we're busy in primary care, it's important to ask those questions at every initial visit, regardless of the age of the patient. So when I see a patient for the first time, we are having an advanced care planning conversation. I am asking them what their end of life wishes are. Many of them are shocked that I'm bringing it up, but what I tell them is exactly what Dr. Min said. I need to hear from you what you want when you can still speak for yourself. You have much more control over how you exit this life than you think you do. So let's talk about what you want, and then I can tell you what we have to offer in order to make those desires a reality. So I think there's still more that we can do in healthcare as it relates to normalizing the discussion before we're in crisis management mode at the end of life and everybody's in a state of chaos. So community outreach, I think, is a big, important way to do it. And then also making sure that we make it a part of every initial visit, regardless of the age or stage of the patient.
Thank you. Mr. Young, I know your population is from a great age, young and old.
Right. So yeah, I mean, I agree with whatever everyone said, and the attention span is very short. for all of us. I used to be able to read novels. Now, not so much. I don't know. So, and social media, of course, is critical. And I loved what Dr. Mann said about the using technology. I mean, technology is a challenge for some people. They're not interested, but there are a lot of older folks who are interested in using technology and do it. I think that sounded like a fantastic product that they had. I love the interaction. I think it's one thing to have the education. It's a whole other thing when there's an interactive piece on the end that keeps them engaged and moves on to the next cycle of the what they need to accomplish. I mean, we've got some other projects out there like that now, different behavioral health screenings, and people complete them, and we get the results, and we can offer them next level care if they're interested. So that's a great way to keep there, but you got to go out and you got to find any way you can, because not every way reaches everyone. Sometimes it's just a special person sometimes that communicates with someone, and that's who they listen to. They might hear it from 5 different people and it didn't make any difference, but one person said the right words, touched it right, and it makes a difference. So that's, community health education is, you got to put out lots of messages. You got to do it a lot of times, and you need to be using different medium. Yeah.
Really well said. So I think we can open it up for questions now, unless Mark, you feel differently.
No, that's fine. I think you guys have a little bit of a stack in the chat. We have an active conversation here.
Who typically are we?
I could try to find. Here's one from Jelly. Does community palliative care team take care of the home caregivers who are exhausted? What are the strategies and resources to help them?
I can speak to that from the standpoint of hospice. Absolutely. When we come in, we're coming alongside a caregiver to help them. And our initial assessment of the patient as we admit them to hospice includes an assessment of their caregiver resources, caregiver needs, caregiver stress, and burnout. Many people don't know that the Medicare Part A hospice benefit includes 5 days of respite care for every certification period. And by that, I mean for those caregivers who are full-time in-home caregivers of their loved ones, a hospice will pay for 5 days for that patient to go to a skilled nursing facility and be cared for, so that their caregiver, whether it's a daughter or a spouse, can just have a moment to decompress. And we can do that for 5 days, every hospice certification period. We also like to make sure that we're taking care of the caregiver after their loved one has passed away. Oftentimes, caregivers end up incredibly enmeshed in the care of their loved ones, such that when that person finally passes away, the caregiver's identity even is sort of shaken, because caring for that loved one has been such a big part of who they are for so long. So we have a 13-month bereavement program after their loved one passes away, so that we can continue to support the caregiver as they reintegrate into a life outside of caregiving. So we definitely want to make sure that we are caring for the caregiver.
I think along that same vein from Zishan about hospice nurses and their encounters with the dying, and what do we do for our frontline workers to combat this mental health impact?
I found debriefing very helpful. You just don't dispel the fact that somebody passed away, that the nurse who had been caring for this patient had a lot of emotional connection. I mean, we talk about transference and countertransference and how as providers we should, really shell ourselves. But this is one field where you cannot just do that. You have to be as human as the other person you're taking care of. I have shed tears, I've held hands, I've said prayers, I have stayed with a dying family as long as they wanted me to be there, even after they had passed away. So you have to be there as the provider, whether you're the physician, the APP, or the nurse. And then once some event like this has happened, debrief to help that nurse feel normalized. It's a lot of times there's no, even if the patient was expectedly going to pass away, there is that sense of guilt of what could I have done differently? Did the patient suffer? Was there anything I could have done to help them more? And sometimes just normalizing those feelings that they're going through and help them just sit, help them express what they're feeling, answer their questions, really helps a great deal when they feel like somebody else out there is actually listening and is caring about how they feel. Just like when in any relationship, whether you have a spouse or children, sometimes you just need to be heard. And that's what we as a team do with our nurses, with each other, to just let things normalize so they don't feel any guilt for whatever happened.
Thank you. From Christine, for patients that have a disease such as Meniere's disease and need to visit the ED frequently for severe vertigo, would or how would palliative care fit into the picture for that patient?
I'll take a stab at that because I answered it briefly in the chat. If you have a person who is suffering from a chronic disease with frequent exacerbations, marked by very distinct symptoms, oftentimes, not always, the patient can help identify triggers that precipitate those exacerbations. So I think the first step of helping them manage and how palliative care can help is doing some exploration with the patient, whether it's symptom logs or journaling, to determine, are there things in my environment or in my life that trigger these exacerbations, right? Because what it does is it empowers the patient, gives them a little bit more control over understanding how the choices they may make might influence the evolution or escalation of their symptoms. The second thing is palliative care can help create a symptom management plan of care. And so if you think about the zone tool, like the heart failure zone tool, red, yellow, and green. I'm green, everything is okay. I'm yellow, I'm feeling a little bit of the symptoms. And by the time I get to red, I'm on fire and I'm calling 911. I really need some help. So helping them understand how their symptoms evolve from green to yellow to red, and then giving them a stepwise approach to managing those symptoms depending upon which zone they find themselves in. If you're in the yellow zone, here are the things that you can do. So for example, I'm a migraine sufferer. I can feel it coming. And I know what my triggers are, right? So having a plan that allows me to figure out what my triggers are, avoid them. If I cannot avoid them, what do I need to do in order to keep myself from getting to that very excruciating stage of an out of control migraine? I know what my plan is. I need a strong cup of coffee, about 800 milligrams of ibuprofen, and Imitrex. That's my plan. And then if that doesn't work and I'm in status, then I'm heading to the ER, right? So having those things sort of at the fingertips of the patient can really be helpful as it relates to managing their symptoms, empowering them to manage their symptoms at home and hopefully avoid having to go to the ER when they have an exacerbation.
There were a couple of comments and questions in the chat pertaining to palliative care and hospice care for the homeless, for folks that are poor in the rural setting, and how do we help them get the care that they need and have the education for it as well. I think Dr. Green, you took a stab at that as well.
Yes, I did. I was trying to keep up in the chat. So for our homeless brothers and sisters, many of them suffer from mental illness. Many of them are also veterans who have served in protecting our country. So in terms of hospice and palliative care for the homeless population, I don't think we can do it without creating ways to collaborate with MHMR, with the Veterans Administration, to hopefully recognize and identify those people who are at high risk for homelessness before it happens. Addressing those social determinants of health, which often put them at risk of becoming homeless. Because what you'll find is many times those that, not all the time, but there are times when those that are homeless actually have some access to resources, but perhaps they don't know it, or they don't know how to tap into those resources. So I definitely think it's important for us to attend to our veteran population and to make sure that we are addressing mental health issues, given the high prevalence of mental illness among the homeless. One of the things we have to have in hospice, for example, in order to take care of patients, is they have to have a place to receive that care. And so if they don't have a home, right, then we can't take care of them. So there are times when getting that social worker involved and creating a plan around addressing those risks are key to being able to position ourselves to take care of their needs at the end of life.
Mark, might I make a comment, please? I don't have a question, but I want to say that I've experienced this phase of life, both from the provider side in hospice and also from the caregiver side. And we've already talked about the pertinence of education so that the expectations are realistic. Against that backdrop, I want to recommend two books. I'm confident many of you know them, but there may be some who don't. One is Atul Gawande's book, Being Mortal, and the other is the Institute of Medicine study of about 2015 called Dying in America. Each of these are wonderful reads, and they are good. I would say they are mandatory reading for people involved in the provider side, and very helpful reading for those who are impacted with this phase of life.
Thanks, Don. Those are very good resources. From Dr. Prothro, sometimes organizational policies have the best of intent, but result in unfortunate interference in providing care effectively. With that in mind, what are some policies that we should keep an eye out for being at risk of marginalizing palliative care access, and how would you raise those concerns to the decision makers? It's a big question.
Well, I think we've always had some risk in the past about especially pain medications, and we've started working our way back into that. Using them. They were used strictly for acute concerns. We're starting back to expand into them at a little more wider these days than we were in the past. So, I mean, that was clearly one thing. It was for a small organization, of course. Sometimes controlled substances can become a challenge to control, to manage. So that's something that we are now evolving our organization and opening back up in that area. We've also, we're pretty heavy into providing MAT services for different drug usage. So that also allowed us to go open more up into back into this area, but it was policy that we were trying to protect ourselves with.
I would also add, I just raised my hand. It's a very quick comment in terms of institutional policies. I think it's really important to watch our language. So what I mean by that is we have a medical order for scope of treatment form at our hospital that we use for some of our advanced care planning discussions. And we ask about CPR. And then we ask about what kinds of interventions people would want near the end of life. And this is the language: comfort care. No, actually, it says comfort measures only. That's one option. Option 2 is select interventions. And option 3 is full treatment. Now, if I had no knowledge of palliative care and you offered me comfort measures only, select interventions, and full treatment, I'm going to select full treatment just by virtue of the language. We make it sound like it's something lesser and leads to marginalization of the care. So I'm very careful. I don't use the term comfort measures only. You've probably heard me say it here tonight. I say comfort focused treatment because it is treatment. It's not measures versus intervention versus treatment. So sometimes even the language that we use in our standard forms in our institutions can lead to marginalization of palliative care, and we need to attend to that.
Dr. Ben?
So I didn't really have an answer. I had more of a question that I was going to pose to Dr. Green, Dr. Risby. It's not necessarily even an institutional policy. I find that we oftentimes run into an issue with the loopholes on surrogate decision makers for patients who are most likely appropriate for palliative care measures, but you have a surrogate decision maker that was just, assigned, and they may not be doing things in the best interest of the patient. So finding a way around that, finding a way to get back to redesignate the decision maker to someone that truly has the best interest of patients is difficult. And so I don't know if the policy behind that, I know the policy behind that is hopefully in the best interest, but at times it's interfering with trying to get to the best interest of patients. A lot of legwork and stuff. Have y'all dealt with that in the past, trying to find a way to change decision makers, find a way to revoke decision making status from somebody? How does that work?
I'll go ahead, Dr. Rizzo.
No, you go first.
Well, I can tell you there have been, yes, there are times when you've got a surrogate decision maker who may be driven more by feelings of guilt or from, another emotional space. So, but what I try to remember is when this person passes away, and eventually that will happen, I am very mindful of trying to conduct these discussions in a way that allows the family to heal after their loved one has passed on, and to do so without worsening the rift that often is exposed at the end of life, right? And so what I try to do when I find that there might be two different camps, or the person who's the MPOA is not the person who really knew the patient well, or vice versa, is to get people all in the same room. Now, this is incredibly time consuming, and it takes a lot of emotional energy. But what I find is that people just want to be heard, and they want to find a way to attend to whatever that underlying emotion is. And so what I've never had somebody removed from being the surrogate decision maker, but I have found myself brokering negotiations between two different factions of family members, all of whom love the patient, but they have different approaches to care. And I think that's one of the reasons it's important to engage palliative care and hospice professionals earlier on in the course, as someone mentioned, you can build the trust that they need in order to feel safe to not only have these discussions, but to make some of those concessions for the sake of healing in the family. So I don't have a nice cookie cutter cookbook answer to that, other than to say, I sit down, I take a breath, I listen, I hold hands, I cry, I get a box of tissues, and we just try to work it out and get everybody on the same page if possible.
Yes, exactly everything that Dr. Green said. I think one thing that I've learned over the years is whenever you have to engage in a conflicted situation in a family, I think the best thing to do, even when we all as clinicians know what is the right next step, it's best to leave our own agenda at the door and meet the patients and their families where they're coming from. A lot of time, just like Dr. Green mentioned, it's coming from an area of concern, of love, and sometimes of guilt that they're just expressing while they're not coping as well as they should be. So a lot of times what I would ask is, what do you think is going on with mom? Because a lot of times somebody lives in California, mom's in Texas, haven't met them in 6 months. 6 months ago, they celebrated Christmas together. Now all of a sudden, what the heck went wrong? She wants everything done. And so all those conflicts that often come are out of guilt that I was away, therefore now I have to fix everything. And you just have to acknowledge that. And it's not important that that first visit with that family has to be the deciding visit. Sometimes it takes 2-3 visits. You have to plant small seeds every single time, exhausting emotionally, just like Dr. Green mentioned. But you just have to plant those seeds and help them see what you are seeing for the patient. And if you can redirect their focus towards keeping them peaceful and comfortable, if that's something they would like, that's what changes their perspective. Eventually, it's a process. I mean, prognosis is a process. Discussions are a process. Nothing happens in one go. When the temperature is up in the room because a brother and a sister were just fighting about how they want to deal with their mom's or their dad's cares, sometimes it's just best to help de-stress, be the human Ativan in the room, just kind of decompress the situation and come back when it's a better time to talk, rather than try to escalate things when the temperature is already up. So it's a process, and all of us who work in this field, I have nothing but the sincerest, highest regard for everything that we go through. One of the questions that just come up here, I would just take Zishan's point about how many palliative care faculty roles have been created in academics, realizing the increasing need of palliative care, especially focusing on training, coaching, engagement, and complex patient management issues. So Zishan, as of today, on August 11th, 2022, it's one person doing all of these things. In other major academic centers, I mean, there are people who are focused on symptom management. There are others who are communication coaches. But for most of us, or those working in the community, it's one person who's delivering each and every aspect of palliative care. And that's why I salute and regard them in such high place.
I'm going to go back to a question further up from Giali. How often do you provide spiritual care to palliative care patients? How to determine if a patient will need it? And do you offer that in a home setting?
Dr. Green, you're in the zone of home care. Yes, and I took a stab at that question in the chat. So the spiritual care is part of the interdisciplinary care team for both palliative care and hospice. So our interdisciplinary teams have chaplains on them, and they are offered at the start of care. It's interesting, sometimes people will refuse the chaplain as part of the interdisciplinary team, but our chaplains stay ready and waiting. Sometimes they will make joint visits with the nurse just to meet the family. And once they get in there, and then folks see that they're not big, scary, beat you over the head with a Bible kind of people, then they're more accepting. So our chaplains make house calls for supportive listening, for prayers. We've even had, last year, we had one of our patients who had a life partner that he wanted to marry before he died. And one of our chaplains performed the wedding. It is not uncommon for one of our chaplains to perform the funeral services for one of our patients that died. So we offer it to everyone. Occasionally, people have a spiritual belief system that differs from the chaplain that has been assigned to them. And when that occurs, we try to find someone that they can connect with within their cultural and spiritual belief. Our chaplains try to provide non-judgmental spiritual support to people of all faiths. So we approach it like everyone needs spiritual care, whatever that means for them. Everybody's different in terms of how they express spirituality. So we try to create an environment on the care team where there's openness and respect for whatever people's spiritual perspective is. And if our chaplains are not initially invited in, we look for opportunities at every care plan meeting to get their input and to get them in the home if we think it would be beneficial.
And we have one other question. I think you also took a stab at it, Dr. Green. Following up on your comments about surrogate decision makers, how early do you begin the conversation about advanced directives with patients and their families, so as trying to avoid those difficult situations?
Yeah, at the very first visit, it's what kind of care do you want at the end of your life, and who will make decisions for you if you get to a place where you can't make those decisions for yourself. And oftentimes people have a ready answer for that. It's my daughter, or it's my husband. And then my follow-up question is, have you talked with them about the kind of care you want at the end of life? And usually that answer is no. So I will often give homework after my initial visit. I used to be a teacher before I went to medical school, so I give homework at my visits. And my homework is often, you need to have a conversation with your loved one. And we offer some resources to help guide the conversation around what kind of care they would want. I think it's important for people to not only make those decisions, but communicate. Just a short personal story. I lost my mom in February. She passed away rather abruptly. It was basically 2 months between diagnosis and death. And I'm the oldest, and I'm the doctor, right? But she made my sister, my little sister, she's 7 years younger than me. She was sort of a lead decision maker. Now, I know my mom, we had talked about this, and she did it because I'm a full-time working mother. I have 3 children, 2 of whom are teenagers, etc. And my mom always said, you've got too many irons in the fire. You're too busy, and your sister is here and she has more time on her hands. And we had that conversation. Now, imagine if we hadn't had that conversation. And then I find out that my mom made my baby sister, who's 7 years younger than me and not a healthcare provider at all, the lead decision maker, how that might create some tension in the family, right? So I share that story to say it's important not only to make those decisions, but to have conversations with your loved ones and tell them why you're doing it. She did it not because she doesn't trust me. She just knows that I'm usually spinning plates, right? And that my sister would have more time. But if you don't, as Dr. Min said, if you wait until there's chaos in an emergency room and somebody's gasping for breath, breathing 40 times a minute, setting 85% on room air, that's not fair. It's not effective. And it's not fair. So I think it's important to do that from the very beginning. And that's part of the normalization of these discussions that we need to have in our culture.
I think we have one more question, and then I'll hand it to Bobby to get final thoughts. This comes from Giali. As an administrator, do you have to consider profits when coming to develop community palliative care. It may not bring in as much revenue as other specialties and teams.
Wow, I guess I'll take that one. I don't, I mean, there's creating a continuum of care means that some services support other services, I think. And, you know, there's great value in providing this care regardless of the profits. So I mean, we all need to, we've got to make enough, we got to bring in revenue to do the work. We need revenue to support a workforce today, which is more difficult than it was 2 years ago, or even last year for that matter. So being profitable is critical. You just kidding, you won't survive if you're not. But there's places where we can bring in revenue that supports these important programs. That's what I believe.
And to the panelists, thank you very much, Mr. Young, Dr. Risby, Dr. Men, Dr. Green. Amazing conversation. For you who joined us this evening, thank you for taking time out of this social join us, it's much appreciated. And have an amazing evening. Yes, here.
Thank you
Thank
all.
you.
Have a good night, everyone. Nice meeting you all.
And take care.
Thank you.
Good night, Mark. Thank you.
Night, Don. Take care.